Gretchen Herring's Foundation, Heart Filtering Foundation.
Okay, so I think we'll begin. Thank you so much for coming, everyone. My name is Amy Sam. I am the Health Education Project Specialist here at the Maxwell and Eleanor Blum Patient Family Learning Center. I help coordinate all of the programming here. Before we begin, please be aware that Mass General will be live streaming and recording this session for Mass General social media. Mass General staff are trained in patient safety and privacy. Staff will not interfere with the presentation in any way. If you're not comfortable asking a question, feel free to write them on the card, raise your hand, or place them in the basket, and I can ask them for you. So today we have Dr. Doreen DeFaria. She is the Associate Director of the MGH Adult Congenital Heart Disease Program, Co-Director of the MGH Cardiovascular Disease and Pregnancy Program, and the Program Director of the Cardiovascular Disease Fellowship. She's here to give a talk today on adult congenital heart disease and pregnancy. So please join me in welcoming Dr. DeFaria.
Great, thank you so much. So thank you everybody for being here today, and to those who are watching online, thank you for tuning in. My name again is Doreen DeFaria. I'm one of the cardiologists here at Mass General. I work in the congenital heart disease, the adult congenital heart disease program, and I see a number of patients who are pregnant with cardiovascular disease and work in collaboration with a number of our other cardiologists with expertise in this area in addition to our obstetricians. So it's a pleasure for me today to talk a little bit, thank you, about cardiovascular disease in pregnancy, and specifically focus on our women and our moms who are born with congenital heart disease, and how we as physicians and providers help to get these women through safe and healthy pregnancies, not only the moms, but also their babies as well. So it's a wonderful field, and we'll go through some overview just to begin. So we'll talk a little bit about the congenital heart disease population, because this really is a growing group of patients that we're seeing. We'll also talk a little bit about how do we identify women with cardiac disease who might be at risk for a cardiovascular problem during pregnancy. We'll talk a little bit more broadly about the growing problem in the United States of maternal mortality. That means moms who die sometime in and around the time of pregnancy or in that postpartum period. And how do we predict which women might have a problem, and how do we best manage them during their pregnancy and after their pregnancy to really reduce the risk of any cardiac problems. We'll talk a little bit about certain types of testing we may do, like exercise testing, that can help us in that risk prediction. And I'll present just a few cases at the end so you can hear some real examples of women I've taken care of over time. So the congenital heart population, so people who were born with cardiac conditions. This is a wide spectrum of different disease pathologies, from what we consider maybe fairly simple problems, an isolated small hole in the heart, to much more complex abnormalities of the cardiac structure and heart function. So congenital heart disease really encompasses many, many different problems. I won't be talking about specific problems today, but know that if you're someone with a congenital heart condition, your risk for pregnancy really needs to be individualized based on the particular cardiac condition that you have, in addition to other factors as well. But many years ago, many decades ago, babies born with congenital heart problems may not have had the opportunity to get a surgical repair during childhood because our surgical techniques were not quite sophisticated enough. And as a result, we saw many children born with congenital heart disease actually would not make it through childhood. They may pass away before they reach the age where they would even consider having a family. Due to the advances of pediatric surgery, pediatric anesthesia, pediatric cardiology and diagnosis, we're able to make these diagnoses earlier, and we have surgical interventions that are now performed on even the smallest babies to correct their cardiac condition and allow these children to have the opportunity to grow and become adults. This is a population of adult patients that a few decades ago we did not see. Now this brings new challenges. As this population is growing, you'll see over the years, not only has the pie gotten larger, this is the absolute number of patients with congenital heart disease, but the proportion, the red portion of the pie, of adults with congenital heart disease has gotten significantly bigger. So adult cardiologists really have to become facile at understanding the nuances of congenital heart disease in the adult patient. Let's talk a little bit about pregnancy and congenital heart disease. So among babies born today, about 8 of 1,000 may have some form of a congenital heart condition. Again, that may be a more simple problem like a small hole in the heart, or that may be a much more complicated problem. Now more than 85, even more than 90% of these children, even with the most complex conditions, survive to adulthood, and that brings them to adulthood with very unique cardiac anatomy and physiology, and importantly, complications. So what might this mean for a pregnancy? Well, women with congenital heart disease have a higher risk of problems related to heart failure during pregnancy. That's fluid accumulation in the body during pregnancy, blood clots, abnormal heart rhythms, and even death during pregnancy. Interestingly, when you look at all of the causes of complications in pregnancy, cardiac disease is unfortunately a very common source of problems. So this is a graphic from the Center for Disease Control where they evaluated among women who died around the time of pregnancy or shortly after pregnancy, within that year after delivery, what were the causes of that maternal death? And we see the cardiovascular causes, having cardiac disease, having some kind of blood clotting disorder, high blood pressure, a stroke, or abnormalities of the heart pump function, all are things that contribute to death of a mother around the time of delivery. Now, although death of a mother around the time of delivery is a rare event, fortunately, it unfortunately is a preventable event for the vast majority of women. So as you can imagine, having a baby is such an exciting time of life. To then be diagnosed with a cardiac condition or a cardiac complication, and even to suffer a severe complication after delivery is one of the most devastating things we can imagine. So whatever we can do to identify these women who are at risk, treat them appropriately during their pregnancy to allow a healthy pregnancy will very significantly reduce the complications that we're seeing. Interestingly, many years ago in the 50s, we studied maternal mortality. We saw the rates were high and we thought, well, what are the things we can do to intervene and reduce maternal mortality? Well, we found in the 1950s common causes of maternal mortality were actually not cardiac problems. They were excessive bleeding and infections and blood clots. Well, those are things that we can deal with and we can treat and we can manage, and surprisingly and impressively, the rates of maternal death significantly declined and really nadired in the mid-1980s. It was around this time in the mid-1980s where we saw sort of a rise in adult patients with congenital heart disease, but a number of other factors have played into what we've seen a subsequent rise, actually, in maternal mortality. If you take this graphic, this overall downtrend, and then extrapolate on to this 1987 study, the new data, our maternal mortality rates are back to where we were in the 1970s. We have a lot of work to do. What also is incredibly surprising is that other developed countries in the world are continuing to see a reduction in maternal mortality. Not in the US. So why is this? Why are we doing less well compared to other developed countries in taking care of our mothers who have cardiac disease during pregnancy and after pregnancy? There are probably many factors, and interestingly, when you look at the breakdown of women who get very sick or who die during or around a pregnancy, there's interestingly a very discrepant racial divide. Black mothers do less well than white mothers. Hispanic mothers do less well than white mothers. But what else are we seeing? We're seeing women who have much more complicated cardiac disease now make it to childbearing age, and they are also ones who have complications. So we have a lot of work to do in the United States to understand why this is, why we are different. Are there biologic mechanisms that contribute to these problems, or are there maybe some social determinants, access to care, insurance, getting people to the right doctors so that they can safely make it through pregnancy. But when I saw this graphic, this was really staggering to me. And I thought we have a lot of work to do. When we look at some of these trends over time, what's happened over the decades from the 1980s until now, in the time when that maternal mortality has been rising, we actually see we've gotten much better at treating high blood pressure, hypertension. High blood pressure is a major contributor to why women can have adverse cardiovascular events in pregnancy, particularly among congenital heart women. Blood pressure is something we can check, we can treat, and we've actually done a great job to reduce high blood pressure. But what has been increasing is women who have underlying cardiovascular conditions, weak heart pumps or cardiomyopathy, and strokes. I'm not sure why this came out this way, but why are women with congenital heart disease at higher risk for pregnancy? I'm not sure why this slide is superimposing this way. Let me go back. Not exactly sure what is happening with the slide. There's a lot of things on top of each other. Might we be able to maybe escape out and start on that slide? That would be great.
Which slide are you on?
This one, yes, that's perfect. Okay, excellent. So interestingly, pregnancy is a really complicated state in the body. A lot of things in the body have to change in order to increase the blood flow to that developing baby in the uterus. The heart has to pump out more blood. This is a graph that demonstrates all these changes. So this is weeks during pregnancy, the time when somebody learns that they're pregnant to delivery here, 40 weeks. And this is change from normal or the non-pregnant state. So you see the amount of fluid in the body rises very significantly. The heart rate rises significantly. The blood pressure doesn't change all that much, or it shouldn't change all that much, but the absolute blood count drops quite a bit. So these are some pretty big changes that happen normally in the body with a normal, healthy pregnancy. And you can imagine that if a woman has an abnormal heart, it might be challenging to deal with all of these major changes that happen and progress over the course of a pregnancy. And part of our job in cardiology in trying to anticipate what problems could happen during a pregnancy is to really understand this physiology very well. In a woman who has maybe a weak heart pump, when they start to see this massive rise in fluid, I know around week 28 to 32, they could start having trouble with fluid. So part of my job is to see them around that time, assess their fluid level, and if they're starting to show any signs of increased fluid, get them on the medication that can help prevent problems. So this really is very unique physiology. It's important for us to understand it very well and really recognize how dynamic it is, because at different phases of pregnancy, there are different challenges to the cardiovascular system. Women with congenital heart disease not only may have abnormal heart pumps, but there are many other abnormalities that come along with congenital heart disease that can put women at risk for a problem. This is a little graphic my colleague Amibat and I made to sort of summarize all of the unique things about congenital heart disease that contribute to higher risk for a pregnant mom. They may have abnormal heart pump functions. They may have prior history of some arrhythmias or abnormal heartbeats that could pop up again during pregnancy. They could have enlargement of the aorta, the big tube that leaves the heart, and that can put them at risk. They may have had surgery before where they've had a mechanical heart valve and are requiring a blood thinner. It turns out blood thinners, if a woman requires blood thinners during pregnancy, that's a very high-risk situation because bleeding can happen during pregnancy. They may have problems with high blood pressure, like you or me, having elevated blood pressure that we measure in the arm, but interestingly, women with congenital heart disease and certain types of congenital heart conditions may have much higher blood pressure readings during pregnancy. And they also may have low oxygen level, and I'll show you another slide about how low oxygen level really can impact pregnancy. This is it. This demonstrates the rate of live birth among moms, depending on mom's oxygen level. So if mom was born with a hole in her heart, and that means some of the blood in the heart mixes, her oxygen level could be low. It turns out if that oxygen level is greater than 90%, there's a very good chance that she'll have a normal pregnancy, that the baby can survive in that environment. If the oxygen level is lower, below 90%, the rate of live birth and miscarriage is very high. So this is important for us to know, and this plays into how we counsel women about their risks of a miscarriage during the course of pregnancy if they have low oxygen levels. So how do we best assess risk? There are many things here that can contribute to risk for a mom who has heart disease. Well, abnormal heart rhythms and heart failure or fluid buildup can actually happen not only during the pregnancy but after as well. This was a paper recently published by one of our colleagues in Canada showing abnormal heart rhythm and fluid, or a marker of heart failure, both during pregnancy, around the time of labor and delivery, which is actually the lowest time, interestingly, and then importantly after delivery. So what this tells us is that our care for a mom with congenital heart problems does not end after the baby's out. We can't say, oh, great, we deliver, great job, because you know what? Mom is at risk for problems for months after delivery. Most moms are very busy taking care of their brand new newborn infant, right? They're not worried about themselves. They don't want to come to appointments about themselves. They're going to their pediatrician, bringing that new baby, caring for that new baby, and they really are not thinking about their own cardiac health. And this is why we run into problems postpartum. We really have to educate our moms how important it is to take care of themselves in the postpartum period. There have been several studies looking at specific risk predictors, so things that we know about mom before pregnancy that may predict problems. I'll just quickly go through. If mom, of course, has had a history of abnormal heart rhythm, stroke, or heart failure before pregnancy, she's at significantly higher risk for those things during or after pregnancy. If she herself cannot exercise very well because she's limited or fatigued, or she just can't walk up a few flights of stairs without getting short of breath, that in itself rings a bell in my mind and tells me that mom may be at risk for a problem during pregnancy. Or if mom has a low oxygen level, like I showed you. If mom has impaired heart pump function, or if she has any blockage of some of the valves on the left side of the heart. These particular issues are things that can put a woman at significantly elevated risk. This was a study that looked specifically at congenital heart disease moms, about almost 2,500 pregnancies, and they found some unique things. The rate of a serious complication being about 11% in pregnancies among moms with congenital heart disease. And you don't have to read all of that down here, but these are specific congenital heart problems, from simpler problems, holes in the heart, to more complex congenital heart problems. And this is the rate of heart failure, fluid buildup, weak heart pumps, and this is the rate of arrhythmias or abnormal heart rhythms. So the more complicated the type of congenital heart problem, the much higher the probability of one of these problems during pregnancy. And I'll just quickly move through even more sophisticated analysis of how we predict risk. If a mom has a mechanical heart valve, meaning she needs a blood thinner, that's a risk factor. Blockage of certain types of valves, history of abnormal heart rhythm, we've heard that one over and over again. If they needed medications for their heart prior to pregnancy, that's a predictor that may have problems during pregnancy. Low oxygen saturation, low exercise capacity, and leaky valves as well. So these are the things that we look out for when we evaluate women prior to becoming pregnant. I always love to see women before they're thinking about pregnancy, so we really can take a nice overview of what their potential risk factors are and to make sure their testing is updated if it needs to be. I'm going to pass through this slide. So that's a lot about risks of mom having poor outcomes, but what about a baby having poor outcomes? Interestingly, it turns out to be all of the same factors, a lot of the same maternal factors. If mom's had a prior cardiac problem, If mom has high pressure in the lungs, that means that the baby could have an adverse outcome as well. Blockages and leakage of valves, poor exercise capacity, reduced heart pump function, low oxygen level, enlarged aortas. If mom smokes, obviously that one is a real important one and really a correctable one that we can work on before conception. And then blood thinners. So a lot of the same things on this list that predict adverse fetal outcomes, baby outcomes, are the same things that predict adverse maternal outcomes. So when we counsel moms, we say this is not only for your health, it's also for your baby's health as well. Sometimes that is often the strongest motivator for a mother. I'm just going to also move past this one as well. Interestingly, post-delivery, we see that women who've had some cardiovascular complication, if they have congenital heart disease, whether it's a simple problem or a more complex problem, are at much higher risk of admission to the hospital for a cardiac reason after delivery compared to women who do not have congenital heart disease. And this is why it's so important that as we train our cardiologists, our fellows who are learning about cardiology and training in cardiology, that we teach them not only about congenital heart disease, but also about the management of pregnancy and some of the obstetrics that maybe many of us felt we kind of had forgotten years ago in medical school, but it is so pertinent to well managing the hearts of our women with congenital heart disease. Anticipate and collaborate. So part of our job is to ensure that we have all of the expertise we need at the table. And we in cardiology don't pretend we know everything about keeping a mother healthy during pregnancy and delivery. We absolutely rely on the expertise of our obstetricians, our maternal fetal medicine colleagues, our anesthesiologists, our cardiac nurses, our OB nurses, to ensure that when we all come together, we're all bringing our expertise to the table so that we think about all the possible scenarios that could occur, that could go wrong in a woman who has risk for cardiac complication during delivery. So important that women who have congenital heart disease are seen by somebody with particular expertise in this arena, in both congenital heart disease and in pregnancy. That we gather all the information we need. So sometimes I meet women and I meet them and they're 18 weeks pregnant, and maybe they have not had any recent ultrasounds or CAT scans, and I'm really not exactly sure what the state of things are inside, and so we need to get that testing updated so we can determine what their risk is. It's always wonderful to see women before conception, so we have some of that testing updated. There's certain tests that we may not be able to do when a woman is pregnant. So gathering all the appropriate information and knowing all of the details is critical to having a very nuanced assessment of risk around the time of pregnancy. And then, as I mentioned, these multidisciplinary meetings to discuss what could the possible complications be. Our group here meets once a month with our cardiologists who have expertise in this area, with our maternal fetal medicine obstetricians, with our anesthesiologists, with our nurses, both from the cardiac floors and the OB floors, to talk about our patients who are actively pregnant with cardiac disease. We review each one of them, their imaging. What are the possible things that could happen? We refer back to that slide I showed you with all the lines going all over the place. When will the fluid rise? How will that impact this woman? When should we get an echo maybe? When should we consider starting a certain medication? Should we think about delivering her in a different environment that will allow it to be a safe delivery if we worry about complications? And so this preparedness, I think, is what is most essential to ensuring that we identify all these preventable causes of problems, cardiac problems during pregnancy. So a couple cases. I see many, many women with congenital heart disease. I see many women who are pregnant. These are just a few examples. This is a woman, a 26-year-old woman with a history of aortic coarctation. I'll tell you what that is in just a second. But she comes in for a routine visit. In talking with her, she tells me she's recently married. She's interested in having a family, which is wonderful. What is aortic coarctation? It's actually a very common congenital heart problem. This is a CAT scan showing the chest. Here's the front of the chest. Here is the spine, so we're looking at the patient from the side. Here is the heart mass, so you don't have to pay too much attention in here because her problem is actually in the aorta, this big tube off the heart. Normally this big tube looks like a candy cane and the blood flow comes out, but you'll see she has this really tight narrowing here. She was born with this very narrowed area of her aorta, which leaves her with long-term problems of the aorta for the rest of her life. Interestingly, coarctation of the aorta, even when it's well repaired in childhood, many of these patients will have high blood, I would say it's almost universal, that these patients will have high blood pressure later in their lives and high blood pressure during pregnancy. You can see later in adulthood their aortas, this tube can get very large and sometimes even tear, which can be a fatal event if that occurs. And then there's also, interestingly, the small risk of having a brain aneurysm. So something that occurs that is funny in the arteries of the aorta may also be going on in the arteries of the brain. There also may be some other associated congenital heart problems, like valve issues or other things we need to screen for. So this healthy woman, interestingly, had not had any recent testing, but she told me she had had surgery to fix her coarctation at age 4. She also had a surgery to repair a hole in her heart sometime later in her life. And she had an abnormal aortic valve, what we call a bicuspid aortic valve, that can be associated with this coarctation problem. She said she's had some mild enlargement of her aorta, but had not had any recent imaging or testing. She feels great. She has no complaints. She doesn't really exercise much, but works daily and feels like she doesn't have any limitations. And her blood pressure, when I saw her at this visit, again, she's not pregnant during this visit, was quite normal. So how do we advise her? This is sort of a wonderful scenario to meet someone before they have conceived, to really think about, what are all the pieces that may put her at risk for complication during pregnancy. So we updated the imaging of her chest, and interestingly, she had a small tear in the artery wall that she didn't know. She was asymptomatic, but that's good for us to know because that could cause problems during delivery. She actually had significant enlargement of her aorta, and she had some narrowing around that area where she had her surgery, and she had some mild narrowing of one of the valves in her heart. We did some brain imaging, and she also, in fact, had an aneurysm, small aneurysm of the brain. So several things. None of these things mean that she cannot have a baby, or that we would advise her not to, but she is certainly at high risk for a complication during pregnancy if we didn't know all of these things and just kind of managed her like any other woman who comes into the labor and delivery floor and is pregnant. So most importantly for her, although her blood pressure right now is normal, we could tell that her blood pressure was going to become a problem later with this pregnancy. And when she did become pregnant, we saw her very frequently. Her blood pressure did start to rise quite rapidly, and we got her on some medications to lower that. That's important because if the blood pressure rises and you have a dilated aorta, enlarged aorta with a tear, that actually could get much worse much faster. So I think that blood pressure management for her, even though it's a simple intervention for us, right? We use pills to manage blood pressure, probably is life-saving for her during a pregnancy. And of course, we discussed her at our multidisciplinary meeting so that when she showed up on labor and delivery, no one was surprised. There wasn't a lot of anxiety about a woman with a high-risk cardiac condition. We had a plan. We knew which medications were safe to use, and she did beautifully well. That delivered vaginally and had a very healthy baby. This is another woman that I take care of who has a history of repair tetralogy of Fallot. What that is a congenital condition where there is a hole in the heart between the bottom 2 heart pumps, and there is narrowing of one of the valves, the pulmonary valve. That's the valve that sits right underneath the lungs. And this is a problem that now can be very well corrected in childhood. We will do this correction in tiny, tiny little babies just a few days after they pop out sometimes, and can correct actually this anatomy very well. But there's certain things that can occur later in life and certain complications that can occur later in life that could potentially impact pregnancy. She comes in, she would like to start a family, and talking with her about her symptoms, she says that she feels very well. She works as an accountant, she has a desk job, she works daily, she does her activities of daily living, runs errands, but she does know she's fatigued quite a bit. She actually often will come home and rest a little bit after work before dinner, which for a 34-year-old is a little bit unusual, right? The fatigue was something she didn't tell me about, but as we talked about the specifics of what she was able to do and the specifics of her exercise capacity, we found she kind of avoids stairs because she gets a little short of breath at the top of the stairs. We found that she has actually stopped skiing with her family because she just thought, well, I'm not good at it, but maybe part of that was it just made her a little bit more fatigued than usual. That was interesting. When I examined her, she had a murmur on exam that sounded like a leaky valve and had not had any cardiac imaging recently. So I said, well, we will get you through a healthy pregnancy if you want to have a family. My job is to help you, to support you, ensure that you and your baby are safe and healthy throughout that pregnancy and delivery. But most importantly, we need to make sure we know all the information of what's going on with your heart before you conceive so that we can really understand your risk and understand how we can best help you during pregnancy. This is an MRI. This is the front of the chest. She's laying flat. This is the back of the spine, and this is the heart. And this is her right ventricle. That's that ventricle under the pulmonic valve that was repaired when she was a small child. And that right ventricle is quite big. And what we found was that she had a very leaky, severely leaky pulmonary valve. We did an exercise test for her because she did describe some limitation, and interestingly, she had a very reduced exercise capacity. When we measured it objectively, quantitatively, compared to her peers, she could do kind of less than 50%, somebody her age, so it was pretty reduced. And the other thing is, we saw that although this right heart pump was enlarged, it pumped very well when we looked at it while she was getting her ultrasound or at rest. But when we exercised her, that heart pump actually got weaker. So that was a good thing to know. It's not something we would have picked up on some of the testing that we did, just a regular resting echo or an MRI. So she has a leaky heart valve, she has reduced exercise capacity, and her heart pump wasn't able to augment or increase with exercise like normal. These things all point to some features that would make a pregnancy higher risk for her. Not things that would preclude her from having a pregnancy or delivery. There are certain cardiac conditions where we say the risk of a mom dying is just too high and we advise women not to get pregnant. This is not that scenario, but she does have several high-risk features. This was a paper that our group published last year looking at this concept of exercise capacity and how that heart pump does with exercise and how that predicts adverse outcomes. So we looked at people who had normal, what we call ventricular reserve. Their heart pumps normally with exercise, compared to people who had some abnormalities in that heart pump with exercise, compared to people who had very severe abnormalities. And the vast majority of these patients had tetralogy of Fallot. Several hundred patients, the vast majority were in the scenario of our woman here. And our woman would have fallen into this red line. She had pretty significant abnormalities in her exercise function and heart pump. We found that how that heart pump does with exercise really very strongly predicted outcomes of congestive heart failure, of arrhythmias, of death of the patient, or of need for transplant. These patients were not all pregnant patients. Actually, none of them were pregnant patients. We don't have any data about pregnant patients and exercise ventricular function, or very little data. So we sort of extrapolate to say if your heart pump doesn't do well with exercise, because that's true in a woman who's not pregnant with tetralogy of Fallot, we would guess that's true in a woman who's pregnant with tetralogy of Fallot, and that puts you at high risk, and we shared this with her. Interestingly, when she delivered, she went almost to term, delivered a little prematurely, had a healthy baby girl, she had heart failure. She did not have heart failure before she was pregnant. She was sort of a normal, healthy-looking person, right? And we managed that with fluid medication. We brought her in frequently towards the end of that pregnancy because we know the fluid was rising, the fluid level in the body was rising at the end of her pregnancy, and we were able to manage that as best we could. And she did well. Her baby was screened for congenital heart disease, and actually the baby did not have tetralogy of Fallot, but had a hole in the heart. So good thing we looked, and the baby's now being followed by the pediatricians. But importantly, remember that graph that showed all of those problems and events post-delivery? We emphasized to her it's really important we take care of you too in this postpartum period, and we saw her very frequently in that postpartum time, and she fortunately avoided another hospital admission in the postpartum time. So I think these two cases sort of represent how one may feel, look healthy, well, and just assume that maybe they would have no problems getting through a pregnancy, but in fact they may have some features that we can uncover in doing our homework and really knowing the anatomy, the physiology of that one individual very well, and we can help them make it through a safer pregnancy. She ultimately had her valve replaced when her baby was 11 months old. Can you imagine having heart surgery and having an 11-month-old at home? I mean, that in and of itself is a major challenge. But now she's doing terrifically well. She's actually back skiing. Her child, I want to say, is 5 or 6. I saw her a couple months ago, is doing very well. And now she's thinking about another baby. So here we go. Lots of babies. So this is really a team sport. We have many people here at MGH. I won't list everybody, but in many different groups, including our obstetricians and maternal fetal medicine and pediatric cardiology, who come together, work together so that we all collaborate, bring everyone's expertise to the table so that we don't miss a thing, and help these women get through safe pregnancies and delivery and postpartum period. And I really hope that this type of care can turn this tide of what we see that is evolving in the US maternal mortality, something that we really need. We have to remember that they are young people, but they actually have older hearts that have been through a lot. We have a lot of work to do to reduce the risks of cardiac complications during pregnancy, because even one excess mother who passes away is one too many. That even sometimes asymptomatic patients may have significant exercise limitations that they don't even realize, and this can be a strong predictor of adverse outcomes, so we have to look. And then specialized expertise is just so critical so that we know all the details and take optimal care of patients. And we always say this, the importance of being intellectually humble and recognizing the expertise that we have in the larger group of people here to take care of these patients is so critical to their success. So that's it. Thank you. Here's my email and office number if any questions come up or arise. Thank you. Questions? Sure.
Just in terms of the appointments, how do they do overall pregnancy or post-pregnancy coming? Do you see a lot of no-shows in terms of?
Great question. So yes, we see a lot of no-shows in the postpartum period. So maybe we've set up an appointment, we've advised mom it's important to come in, but again, sometimes priorities change when you have a small newborn, and it may be that their appointment is the one that's missed when they keep the appointment for the baby. So we keep track of them. If we see them not come into clinic, we'll call them. I often try to coordinate their visits on the same day as other providers. So if I can see mom the same day she's bringing the baby in, absolutely. If I can see mom the same day she is coming to see the obstetrician, I will do that. The great thing about cardiology in our Yawkey building is cardiology is on the 5th floor, pediatrics is on the 6th floor, and OB is on the 4th floor. So if I have a woman who I know is having an OB appointment, I'll just run downstairs. And I'll see them, I'll walk into the OB clinic, they all know that I pop in there occasionally, and maybe I'll examine them real quick. So that's not always feasible. So, but as best we can to coordinate visits, that does improve the likelihood that somebody will come back and follow up. So lastly, I just want to thank again the Anchorwood family. Eric and Lori are sitting in the back. They have founded a tremendous foundation, the Heartfelt Dreams Foundation, where the core mission of this foundation is to help congenital heart disease patients get to see providers with specialized care, to help us educate the cardiology community about congenital heart disease, and to help support cardiac nursing as well. So I just want to thank Eric and Lori for supporting our efforts in spreading the word and educating people about congenital heart disease. So thank you.
Thank you.